Oh, this meeting is being recorded. Okay.
Yeah. So, hi, I'm Reliable RN, Kathleen King, and tonight we're going to talk about lungs, all things that have to do with lung health and issues when we get either diseases, chronic diseases of the lung, and or acute illnesses. I'm going to go straight into a screen share and just bring up the program. All right. So, COPD, asthma, and lung function. That's where we're starting tonight. Again, I'm Kathleen King. Also, my business is Reliable RN, and the website is www.reliablern.com. So, what is COPD versus asthma, and what do normal lungs do? Normal lung function. So, in terms of the muscular and skeletal, right? So the bones and the muscles, your chest expands, right? It comes out, and that brings air into your lungs. Your diaphragm contracts, then your chest contracts and your diaphragm relaxes, and that pushes the air back out, and that's called exhalation. So your diaphragm, your ribs, your sternum, that's that center bone in the midsection of your body. Also, normal function. We take in oxygen, O2, and that gets exchanged down at the alveoli level. So if you think of lungs as a tree that's growing upside down, it's the part of the tree that's like the little twigs and maybe even branches, twigs and maybe even leaves. And that's the alveolus. So at that spot, oxygen goes into your bloodstream and it pulls off CO2, carbon dioxide, which is a waste product of our body. And then the last thing, this is the plumbing that has to do with breathing. So we have nasal cavity and oral cavity, right? You can breathe through your nose or through your mouth, right? Esophagus is that pipe that goes to your stomach. We don't want air going down there, and we don't want food down your trachea. Your trachea is the big tube that feeds both lung areas. And from the trachea, you have the bronchus, which are the next big, almost like the branches, and the bronchioles, which would be more like the twig-like structures if you're thinking of an upside down tree. So the tree trunk is the trachea. The bronchus is kind of your big branches that are coming off the trunk, and your bronchioles are the twigs and the smaller branches that come off the main branches. And in the normal view, you have normal bronchus it's just like a tube, like an open piece of spaghetti, rigatoni, I think. And above it, if you look that at the alveoli, they actually should look like a bunch of grapes. When they're healthy, they look very much like grapes on the vine. Abnormal alveoli, though, however, can get mucus. And also, sometimes they kind of start to clump together, so they're not as individual as they're supposed to be. That can also become a problem, right? So if you look at the abnormal bronchus, it's inflamed, so it's more narrow, and sometimes there's mucus in there. Okay, steps of normal inhalations. That's breathing in, right? When you take a breath, the air goes in through your nose and mouth, travels down your throat, through your voice box, into the trachea, also known as the windpipe. At the end of the trachea, it splits into an upside down Y, and that forms the bronchi, right? The bronchus, the big tubes. And they either goes to the right or the left. Inside the lungs, the bronchi branch off into these bronchioles, which look similar to the smaller branches of a tree. The air flows through the bronchioles, which keep getting smaller until it reaches the ends of the branches. And at the ends are these clusters of little pockets that collect the air, called alveoli. When the air reaches the alveoli, oxygen goes through the membrane into small blood vessels called capillaries, and carbon dioxide comes into the small capillaries in the alveoli and actually gets expelled through your lungs, right? So we're going to take in oxygen and we're breathing out CO2. Standard stuff. Exhalation, that's the breathing out part, right? Second stage of breathing. There's always two parts. There's the breathing in, but you also have to breathe out. Okay. After the oxygen and carbon dioxide trade places in the alveoli, the diaphragm relaxes and positive pressure is restored to the chest cavity. And that forces the used air out of the lungs. And going to make you do it all over again. Your body knows that if you force all the air out, you automatically are going to need to take a breath in, right? We breathe 12 to 20 times per minute for a healthy adult. A child is a little faster than that, usually about the 20 times a minute. The younger the child is, the faster they might be breathing. And that's all very normal, all very normal. We determine lung function by how much air we can move in and out of our lungs. So if you went for lung testing, so let's say you had asthma, or they suspect you have COPD, they might send you for some lung testing. And we use tools like spirometry, a lung volume tester, diffusing capacity. And we also can measure your lung capacity with exercise testing. So this is a classic graph of what normal lung function should look like and what it looks like if it's diseased. So notice it's looking at volume exhaled. The majority of illnesses that have to do with lungs have to do with our ability to exhale air, not take it in. And you can have asthma and you can tell me, no, Kath, I had asthma and I'm telling you, it's like impossible for me to breathe in. Well, it's impossible for you to breathe in because you're not effectively breathing out. You have to get space in your lungs to be able to take another big breath. If I kept all the air in my lungs, I can't take any more in. I got nothing to do. I have to let some out to take some more in. So volume exhaled versus time. So in a second's time, look at that red graph. That's the normal. That's our normal lungs. That's how much air it's going to expel back out when it's exhaled. Restrictive diseases are that yellow. So restrictive has to do with body shape. Kyphosis is the rounding of your shoulders. People who walk bent over. Obesity. MG is myasthenia gravis, or ALS. Things that restrict your ability to open your lungs, open your rib cage, expand your diaphragm. Those are restrictive diseases. And then there's these obstructive diseases. And so look at that blue. Look how big the difference is between normal lung function. That's obstructive diseases are your COPDs, your asthma. That's why you feel like you can't take a deep breath, because you're not able to exhale at the same level. So obstructive versus restrictive. We talked about this. Obstructive is kind of what happens most of the time, but let's just talk about restrictive for a minute. Restrictive lung disease, these are chronic diseases, or they could be acute diseases like a rib fracture. You're in a car accident, you break 3 or 4 ribs. You're not going to take deep breaths. You have restrictive lung issues. Pulmonary fibrosis, that's a stiffening of your lungs. Once your lungs get stiff, you're not going to be able to fix that. That's an intrinsic restrictive issue. It involves scarring and inflammation that's not going to go away. Extrinsic usually involves the chest wall, pleura, and muscles. So that's normally like what we said before, rib fractures. It could be for somebody with COPD, with heart failure, right? So if you have heart failure, maybe you have fluid in your pleural area, and it's hard for you to move the muscles, to move your diaphragm, to expand your lungs. And so you end up with this restrictive lung disease. Obstructive, on the other hand, that's something that blocks or narrows the airways. Whenever you have blocking or narrowing of the airways, That's obstructive. It usually stops the lungs from expelling air optimally, and that leads to poor inhalation. Air can't get in. There's usually no cure for most obstructive illnesses. Sometimes something like an allergy, you could take allergy medicine for. Asthma, you can control using medications, but typically once you have asthma, you're going to carry that for the rest of your life. So we use medications, we use physical therapy sometimes, and we use breathing aids. For this talk, for the purpose of this talk, we're going to focus on this 80%, the obstructive illnesses. All right, so that's COPD, asthma, CF is cystic fibrosis, and emphysema, which carries a little bit the same with COPD. All right, so here's COPD. Classic pictures here. So normal bronchus, pretty wide open, no big deal. Look at the bronchitis side of this. In bronchitis, the actual tube is much more narrow. There's inflammation, and there's also mucus. There's very often mucus in there. Normal alveoli. Again, if you look at the bottom picture where the blue is, it gives you that like grape appearance, that bunch of grape appearance. But with emphysema, see how they kind of the walls between them break down. So instead of having lots of little circles, you kind of only have one big, almost like flower looking piece. That restricts the ability of oxygen and CO2 to exchange at the capillary level. And your symptoms would be a chronic cough, fatigue, chest discomfort, production of mucus, shortness of breath, dyspnea. Dyspnea, it means shortness of breath when you're doing something. You want to walk upstairs, and by the top of the stairs, you're like that. That would be dyspnea. All right. Stages of COPD. Mild, moderate, severe, very severe. Mild. Your airflow is 80% of normal. So you're pretty close to normal, not quite perfect. You might be winded with moderate exercise. Compare that with stage 4 or a very severe case. You have low oxygen levels. Your airflow is less than 30%. Flare-ups in this range can be life-threatening. Lung illnesses in this range can be life-threatening. And sometimes people with these low oxygen levels do actually have oxygen at home. Sometimes in this later stage of COPD, we do give them oxygen at home. Asthma. Why is asthma different? So asthma is different because generally you have the normal airway, again, nice kind of big opening. An asthmatic airway, even if it's not asthmatic airway, even if you're living your best life, you don't have any symptoms of asthma, it's already inflamed and it's thickened. So you don't have as much space to move air. It's still pretty open, but you don't have as much. Look at it during an asthma attack. The smooth muscles that line the tubes, the bronchi, actually tighten. Like rubber bands around, if you put rubber bands around a finger and you kept tightening them, and you get those bulging areas of your, where things are, where there's restricted blood flow. You get these restricted areas, you have very little air movement, and the air actually gets trapped in the alveoli, which means the CO2 is trapped in there. We can't get it out so we can get new oxygen, which is why people feel like they can't get a good breath. So what do we do for this? So ignore all the pink and the red. That's kind of high level stuff. I know what it is, but you don't need to. For allergies and asthma, we typically use what we call bronchodilators. Bronchodilators are things like inhalers, albuterol. The thing goes, sometimes those are steroids too, but usually a bronchodilator is your albuterols, your inhalers. And an asthma or allergic reaction might also use anti-inflammatory drugs. Again, often those are steroids. It could be an inhaled steroid like Pulmicort, or it could be a steroid like a Solumedrol pack or an IV Solumedrol. Those are for allergic and asthma reactions. For COPD, we're going to use all this stuff. somebody with COPD will most often have an inhaler. They will also have some anti-inflammatory drugs. Sometimes they take daily steroids, right? So they take a daily 5 milligrams of prednisone, let's say. That's an anti-inflammatory drug. And then the mucus clearance therapy. So a lot of times that is a nebulizer or medicine you put in a nebulizer that actually helps to break up mucus. We were using Mucomist for a while. With Sinafin is another one. There's been some question about how effective that actually is. But that's mucus clearance therapy is expectorants. How do we get the mucus up, out, thinner? Water, drinking more water helps to thin mucus so that you can cough it up. So airway clearance, that can be physical airway clearance, like, and then getting rid of the mucus. And bronchiolitis, that is pretty much like when you have bronchitis or reactive airway disease. So you can't stop coughing. You're sure there's mucus in there. They're going to use those anti-inflammatory drugs and the mucus clearing. It usually is not because the tube is too narrow. It's usually that there's too much mucus. Cystic fibrosis. This is a horrible disease. People used to actually die of cystic fibrosis in their early 20s or mid 20s. They are now living much longer lives. Some, I would say, even full, normal lifespans. But it's a horrible, horrible disease because the fibrosis means you're essentially causing thickening and stiffness to your airways. And on top of that, it's creating a ton of mucus. Excuse me. So that mucus is thick, it's sticky, and it's actually just really hard to get rid of. People with cystic fibrosis have a partner or a physical therapist that essentially almost beats on their lungs, on their backs, to try to get them to cough up this thick, sticky mucus. And they do it every morning just so that they can get through their day. It's really kind of it's a horrible disease, and they definitely feel like they're drowning in their own mucus. All right, so we just talked about lung diseases. All right, so those were chronic illnesses that have to do with the lung. I want to move on to just lung infections. So lung infections are short-term infections. They're either bacterial or viral. And let's talk about, because I think most people have to deal with this, especially in winter months, pneumonia versus RSV versus a chest cold. So pneumonias. A pneumonia can be either viral or bacterial. So viral cases of pneumonia usually begin with congestion and a cough. And when a doctor listens, they can hear junk or wheezing or what we call congestion on both sides of the lungs, right? So it's not, it doesn't matter whether I'm listening to the right side or the left side. I kind of hear the same sound on both sides. However, a bacterial infection, a bacterial pneumonia, typically is only heard on one side. So this junkiness, this congestion is heard on one side of the lung. And that's because bacterial pneumonia tends to aggressively attack one lobe or one section of lungs. So it causes a specific area of inflammation as opposed to kind of an all over congestion. So, but the other thing I wanted to point out is that often doctors will diagnose pneumonias based on listening to lungs and symptoms, but the only definitive way to diagnose pneumonia is a chest x-ray. Anything else is best guess. And I'm not saying that's bad, but you really cannot definitively diagnose a pneumonia unless you have a chest x-ray. And even those are not both as definitive as I'd like. RSV versus a chest cold. So I think a lot of people have heard of RSV now. We typically knew it as a pediatric illness. Children 2 and under, it can be life-threatening for, but has always been known as a pediatric illness. However, what we found, in part due to testing during COVID, is that adults 65 and over who have lung conditions actually are more susceptible to a poor outcome with RSV. So they're both viral infections. RSV is becoming a little more of an issue for chronic lung illness people. And about, they say up to 15% of people in an ICU might have this RSV in the wintertime. So in adults, the problem is it usually comes on feeling like allergies or a common cold, but after 2 or 3 days, it's not getting any better, and you actually start to feel worse. That's when you should probably go see a doctor about the RSV. Chest cold, generally no fever, yellow or clear nasal discharge, even if you have a cough and you cough stuff up, if it's yellow, clear, white, we're not going to worry too much about it. It's probably a chest cold. Tends to get better within a few days or with treatments like warm compresses, Vicks vapor rub. You take a cold medicine and you feel better. That tends to be a chest cold. RSV, the problem with RSV, the real problem that they have is it looks just like a chest cold. And unless you run a swab, you're probably not going to know until somebody's very ill. Ways we damage our lungs. So this should not be news to anybody, but I put it in here because I think it's critical that we, you know, make an obvious connection. Smokers. Smoking is bad, vaping is bad. Does two different things. Smokers um, kill cells differently than vaping does. Vaping, if you look to your right side, those kind of like holes, when we see that on imaging, they call it popcorn lungs. So that's a specific problem to vaping. They create popcorn. And if you look, it's like the alveoli that should look like a bunch of grapes, instead look like a bunch of popped popcorn, which means they're not doing their job and somebody's having trouble breathing. And you definitely get mucus. That's always a problem. Smokers, the same thing. But, the encouraging thing is that if smokers, within a few years of stopping, they are 20 to 40% of their cells are near normal. So you can heal your lung. Your lungs do have the ability to heal themselves, but smoking is a big one for us for lung injury. Asbestos, most people have known about that. So workers being exposed, the 9/11 the men and women who worked on the pilot 9/11 would have been exposed to toxins. People in mines sometimes are exposed to toxins. That is certainly injures the lungs. But the majority of us don't damage our lungs unless we are smoking or vaping. The majority of us. The current CDC guidelines for smokers in terms of lung cancer concerns. We don't have guidelines yet for vaping, but I'm sure they are coming. But right now, for somebody who is a smoker, if they have a 20-pack year history or more, and they smoke now or have quit within the past 15 years, and are between 50 and 80 years old, they actually should be screened every year. So they do CT scans for them every year because in general, lung cancer is caught at stage 3 or 4. We generally do not catch it early, and that's a real problem. So for people at high risk, for smokers especially, these are new guidelines. And so I just wanted to bring them up so that people would, follow the guidelines. What's the way to protect your lungs from illness? So let's say you're not, Kath, I'm not a smoker. I do what I can. Vaccines. There are certain vaccines you probably should get. Daily walks in the fresh air. Essential. Fresh air is great for our lungs. We need outside air. We need not air that's recirculated and air conditioned. If you can handle the outside air, it's just a good way to build immunity. Deep breathing exercises. These are easy. Some of us do them naturally, but like yawning, oh, is a great way to open up your airways. We always want you to try to get enough air to open up the lower parts of your lungs. That means not sitting back in a chair, but sitting up tall. So your lungs can expand forwards and backwards, right? So your front can expand and your back can expand. So pull your body off your chair and let your lungs expand. Deep breathing exercises. These are huge. Current vaccine recommendations. So RSV and flu. One, I'm going to just be clear about this. It's always best to check with your PCP or your pulmonologist to determine which vaccines are best for you based on your underlying medical condition. I am not recommending or not recommending vaccines. I am telling you what the recommendations are from the CDC for as of today. RSV and flu. For RSV, adults over 60 or pregnant women are eligible. It's 83% effective at preventing illness, 94% at eliminating life-threatening cases. So that kind of runs a little bit with the COVID, right? For flu, all adults are eligible unless you are allergic to the ingredients. Effectiveness of the flu varies from year to year, and neither vaccine is considered a lifetime vaccine. They're saying that the RSV is kind of closer to the flu. They don't know how often they'll have to give it, but they're not considering it a lifetime vaccination. They're considering it a short-term vaccination. Flu is yearly. They expect everybody to get a new one every year, and they try to match the correct flu. Sometimes they're right, sometimes they're not. Pneumonia or the pneumococcal vaccine. Now this one is the recommendation is so difficult to follow that they actually have a helpline, like a 1-800 line for people to check. It is recommended for adults 65 and older, or for 19 to 64 if they smoke. So if you're a non-smoker, 65 and over. If you're a smoker, anytime after 19, you're eligible. For older adults who don't have an immunocompromising condition, so if you're a healthy older adult is over 65. If you're a healthy older adult, here's what it says. You have to actually know which vaccine. If you got PCV15, then a year later you should get PPSV23. But notice what it says after that. Then your vaccine will be complete. Lifetime complete. Now, if you got the PCV20 at first, then it doesn't need to be followed by a dose of PPSV23. Your vaccine is complete as soon as you get the PCV20. And the reason I want to be clear about this is because for somebody who's 75 or 80, if they've ever gotten a pneumonia vaccine, a pneumococcal vaccine, they are done. There's no guidance that says that giving extra vaccine is going to make you safer in any way. Check with your doctors. You can call the 800 number to check, but pneumococcal vaccination is considered lifetime after it is completed. So whether it's the 15, then the 23 a year later, or the 20, once you get it, you are done, right? You're safe, you're good. Okay. All right. So you know me, I always like to leave with what can we do to keep our lungs strong and healthy. So one, if you're smoking, quit smoking. Avoid secondhand smoke. Also not rocket science here. Limit your exposure to pollutants. So big cities, people who travel to China or even Japan, in some places of Japan, there's a reason they wear masks. And it's actually because of airborne pollutants. Remember, a lot of pollutants in the air are tiny fine particles. And if you breathe them in, they will settle in your lungs. Again, asbestos would have been, for the US, one of the most well-known. But black mold, same kind of thing. That's a lung issue. To be strong and healthy, do deep breathing exercises daily. Again, all that means is 2 or 3 times a day, I'm going to take 3 really deep breaths. Sometimes it's a count of 5 in, hold for 2 or 3, and out for 5. Play a wind instrument. That's really good for your lungs. Anybody who plays the trumpet, saxophone, they'll tell you it's good for their lungs. Improve your indoor air quality. They're talking about house plants. I will even say a lot of people use um, air fresheners in the house. Air fresheners have been known actually be lung irritants. So be very careful about scents or air pure. They're not purifiers. They it's the Febrezes of the world. Those are not good for your lungs. They're pretty well known not to be good for your lungs. All right. As always, that's the end of this one. I am Reliable RN. My mission is to educate and empower. Available services. I do nurse coaching. I do medical advocacy, and I also can do care transition for relatives or for yourself if you find yourself needing to think about hospital to home, hospital to rehab, rehab to home, assisted living, can do that. So thank you so much for listening. Nice to see you, Hershey. I can see you there. And I'm going to stop sharing at this point because I wanted to know if anybody had any questions. I don't think either of you are muted, so you should be able to ask questions if you want. No questions? If there's no questions, then do me a favor, if you're both still on, before we go, can we just take a couple of really good deep breaths? I'm going to do just box breathing. So I want you to think about a box or a picture frame. We're gonna count to 4 and go up the picture frame. That's your inhalation to 4, then hold it for 4, then release it for 4, and then wait again for 4 seconds, and then we'll go back up. We'll just do this 3 times. Okay, so it's like this. It's just a good way to get a fair amount of air into your lungs to feel like they're opened up. So thank you for joining me, and I'm going to stop the recording at this point, okay? Thank you.
Thank you.